Hello again. I'd like to introduce Elaine. She's 73 years old, and she's really a perfect candidate to volumize the dorsum of the hand. The manifestation of really in her hands of severe volume loss, and you can see the exaggeration of the tendons. So on a Mertz global hand scale, she is a grade 4, which is a severe, meaning that there's a very significant volume loss, prominence of the tendons, and also very visible dorsal veins of the hand. And again, she's an ideal candidate for volumization of the hand, and we'll be using calcium hydroxyapatite, 2.5 cc's, which is derived by diluting 1.5 cc vial of calcium hydroxyapatite with 1 cc of 1% lidocaine to volumize the dorsum of the hand. And really, depending on the severity of the volume that's lost, I adjust the amount of injectate that I use per session. In Elaine's case, we'll be injecting a vial into each hand because, again, I think that the severity is right there. The other thing that I'd like to mention is that really it's a combination treatment, treating the dorsum of the hand to rejuvenate the hand. Not only is it about the volume, not only is it to diminish the prominence of the tendons and the veins, but it's also about the superficial color of the hands. And Elaine is really a perfect candidate also for a BBL that we use in my practice, which addresses the hyperchromaticity, so to speak, or the pigmentation of the dorsum of the hand. You can do it in conjunction with the volumization or separately. I use a 22 gauge 50 millimeter blunt tip cannula for injection. I mark the approach, and I just want to show you something, that the importance of using a proximal to distal approach is that it really is in the same distribution anatomically as the distribution of the tendons, as you can see. Some physicians use a retrograde injection where the injection points are 3 between the metacarpals, and it's really a retrograde injection. My point is that this is less traumatic, of course, because there's only 1 injection point versus 3, and again, it's in a natural anatomical distribution. Next thing that we'll do is just renumb up the injection point using 1% lidocaine solution with epinephrine of 1 to 100,000. The other thing that I do is I use my loops. I think it's just so much easier. Also, the injection point is made with a 21 gauge needle through which we insert the cannula. And just another teaching point is just to tent the skin and puncture the skin. The correct plane of injection is into really the superficial fascia and scraping almost the undersurface of the dermis. The reason for that plane being the correct plane is that there is a potential space into which the filler is absorbed or accepted very easily. The hands, of course, the hand was cleansed with alcohol before the injection was done. And again, that's very important. Again, what I'm doing is just tenting and introduction of the cannula already happened. Just gently relax your hand. Here we go. And you can see how that cannula just very smoothly travels in that space. Again, this is a grade 4 on the Mertz global hand scale, showing a very severe loss of volume with prominence of the tendons and the dorsal veins. And you can see that by using a blunt tip cannula, the veins are displaced from the tip of the cannula without being perforated. Utilizing a needle can be done. The problem is, or the issue is, at least in my opinion, that I'm just transferring the rest of the mixed material. The problem is that using a needle is much more traumatic because with each puncture, of course, there's more of a chance of puncturing the vein and traumatizing the tissue. So in my practice, I just gently bend your, that's it. In my practice, I use the blunt tip cannulas. I think that's easier for the patient. I think it's less traumatic, less painful to the patient. And you can see how the veins are just very easily displaced. Also, utilizing and measuring the access point allows you to reach the very distal tip, right between the metacarpals. So the material has been delivered. Lorraine, could I have a little bit of Aquaphor, please? Just make a fist, please. And one way of doing that is to be very aggressive for me to massage it into place. And I just put a little bit of Aquaphor onto the dorsum of the hand, and you can see how the material is really very well distributed and very evenly distributed. And this view, of course, points out to you that I have eliminated or severely or markedly reduced the prominence of the veins, loss of volume, and the prominence of the tendons, yet we didn't do anything to the hyperchromia of the dorsum of the hand, for which light therapy, a BBL in this case, is perfectly indicated. What I typically do is see the patient, just make a fist again, see the patient about 4 to 6 weeks after the injection to see if another treatment is necessary. And in Elaine's case, most likely that will be done, because you can see that the reduction was significant. We really went from grade 4 to grade 2, but I think we can inject more material to reduce it closer to 1 or 2 grade. I would not do it in one sitting, because I think the more volume you inject, whether it's hyaluronic acid or calcium hydroxyapatite or PLLA, the more swelling the patient undergoes. We're finished with the left side, and we're just going to go to the other side of the hand, of the body. And you can see the tremendous difference between the injected hand versus the non-injected hand. The very prominent veins and the tendons are essentially gone with injection of calcium hydroxyapatite. Thank you.